Hello, thanks for joining me today. Today I'll be doing a presentation on transcranial magnetic stimulation, or for short as I'll be referring to it as TMS, and how it can be used to treat major depressive disorder. Some things that will be covered here today include the neurobiology of depression, how TMS works from a physiological standpoint, reviewing the evidence for TMS and its efficacy, critically reviewing the various studies about TMS and MDD, and exploring TMS's limitations and potential future research directions. TMS is a non-invasive brain stimulation technique which uses magnetic pulses to stimulate specific parts of the brain. An electromagnetic coil is placed on the scalp and the electromagnetic fields pass through the skull and activate the nerve cells, with the overall idea being that you can modulate the neural activity with the electromagnetic field, and by targeting and stimulating specific parts of the brain, the parts that are found to be responsible for major depressive disorder, you can treat the disorder non-invasively. MDD, or major depressive disorder, is characterized by a persistent low mood, anhedonia, changes to sleep and appetite, cognitive impairment, and functional impairment. And there are already treatments for MDD, such as psychotherapy and antidepressants. However, a substantial amount of people do not respond to these, which is why TMS has gained traction, and attention clinically is a potential alternative treatment. To understand how TMS might help with MDD, we have to identify the key structures in the brain that are involved with MDD, and the region of the brain that is shown to be very, very influential with people with MDD is the dorsolateral prefrontal cortex, and research has shown that people with MDD, this area of the brain has reduced cognitive activity. The dorsolateral prefrontal cortex is responsible for higher order signals and essentially guides the brain's emotional centers, such as the limbic system. Some examples of limbic structures involved are the amygdala, hippocampus, and subgenual cingulate. These limbic structures appear to be hyperactive and dysregulated due to the signals from the DLPFC, which is the dorsolateral prefrontal cortex, shortened, abbreviated, DLPFC, which contributes to the negative emotional imbalance and depressive symptoms overall. Due to these symptoms being dysfunctional, neurotransmitters such as serotonin, norepinephrine, and dopamine are also affected and become imbalanced. And these neurotransmitters being out of whack has been long linked to depression. The consensus among scientists is that while that's part of the picture, what's important, not just the neurotransmitters themselves, but it's how the brain cells connect, talk, and grow with each other there. Things such as synaptic plasticity, neurotropic factors, and network level dynamics are key influences in MDD. And this is why TMS is such a promising treatment for MDD, because it's by stimulating the key areas, such as the DLPFC, it can help to rebalance the whole network and not just the chemicals, which, for example, SSRIs, might just treat the, serotonin, reuptake inhibitors, the serotonin part of it. How TMS works. So, simply, it's by placing a magnetic coil close to the brain region that you're being targeted, which in this case is the DLPFC. The coil produces a magnetic field which passes through the skull and the scalp without much interference, and the magnetic flux creates an electric field in the targeted areas of the brain, which can depolarize the neurons if the current is strong enough. In repetitive TMS, which is also called RTMS, these electrical pulses are delivered repeatedly, and in frequencies greater than 5 Hz, it creates an excitatory effect on the neurons. And frequencies around 1 hertz or lower are considered inhibitory. So you can control whether it's, whether it's excited or inhibited based on the frequency, whether it's high or low. And through RTMS, synaptic plasticity is induced, which is a change similar to long-term potentiation or long-term depression. And so the way that TMS is used clinically, most often for MDD, is with high frequency stimulation of the left DLPFC on the left side, with the aim being to boost underactive frontal circuits. So the clinical evidence, there is a growing body of evidence that TMS is effective for treating depression. The evidence comes from randomized controlled trials and meta-analyses. George et al. Conducted one of the largest modern trials using 10 hertz of the RTMS to the left prefrontal cortex over multiple weeks, which is exactly what we were just talking about. There was a significantly greater antidepressant effect when compared to the placebo group in terms of response and remission rates. And there was an earlier trial as well, which helped to build a case with the FDA approval process in the United States, which was done by O'Riordan, and this demonstrated better outcomes for the real RTMS over the placebo once again. And what this earned it from the guideline level, it was rated a level A, which means it was rated definitely effective as a treatment for treatment-resistant depression. So to summarize the efficacy, TMS has a solid amount of evidence that it's effective treatment for MDD, especially in people who saw no improvements with mainstream medications or SSRIs. So there's promising evidence to support TMS in treating MDD, but there are also limitations to be considered. First of all, the placebo trials in many cases actually yielded decent improvements in MDD symptoms, which naturally calls into question whether the real TMS therapy helped as much as what we thought. The placebo trials were very convincing as well. They mimicked the click and scalp sensations that you would get with the real treatment, but without any actual brain stimulation, of course. Another limitation is the high rate of non-responders to the TMS treatment, which is estimated to be 40 to 50% even in the responder-targeted populations. The antidepressant effects of TMS have shown to dissolve after a few months as well, which has been shown by follow-up studies, such as Dunner's study, 2014, which means that patients they can relapse unless maintenance or follow-up sessions are used. Also, there was issues with the protocol standardization because across different studies they used different coils, different stimulation intensities, and different ways of placing the coil with the neuronavigation versus non-navigated targeting, and so all of these factors introduce variability, ruining the standardization in some ways. And finally, there are practical limitations with the treatment option being, expensive and time-consuming, with daily sessions required in 4 to 6 weeks. And so, yeah, it's practically it's not the best at the moment. So mechanisms and efficacy. Do the mechanisms match the outcomes? And kinda. So physiological models of how TMS work, they're not fully understood. In some studies that look into the brain imagery and connectivity, they suggest that it's correlated with the normalization of prefrontal limbic connectivity, which is done by Fox 2012. An example of this is increased coupling between the DLPFC and the subgenual cingulate, which would support the hypothesis that the TMS is doing some kind of circuit reset and restores normal brain communication. But on the other hand, not all responders show the conductivity changes that are expected. Results are inconsistent. People aren't sure why yet, which means that the TMS may work through only partially understood or indirect mechanisms. So to summarize, the current mechanistic model provides a good scaffold, but it's not concrete as of yet. So a couple of potential future research directions, personalized TMS targeting, because at the moment, instead of putting the coil in the same spot for everyone, you can use an MRI scan or an EEG to guide the coil placement so that it can be placed where the individual patient's brain requires the recalibration rather than putting it in the same spot. Faster TMS sessions accelerated through theta burst techniques. Yeah, so it can deliver the same effect in a shorter time by delivering more frequent pulses, but it's still at its beginning stages with evidence still emerging, so it's not considered reliable yet. Combination treatments, so using TMS with psychotherapy and medications to see if the effects are stronger or last longer. There needs to be more long-term studies done to determine how often the maintenance sessions are needed, because if they are dwindling results, diminishing results, then yeah, you have to see when the therapeutic effects begin to diminish so that you can give booster sessions or whatever. And so if some of these ideas are developed, TMS can become more accurate, quicker, easier to access, and better at keeping depression away long term. To summarize, TMS has shown a promising start as a non-invasive treatment for MDD, though it's not fully clear which mechanisms are causing the therapeutic effects. But at least we do have a solid scaffold for future research to build upon, so that these questions might be answered. Its physiological basis does align with what we know about depression from a neurological standpoint, but yeah, with the limitations being that large amount of non-responders, diminishing therapeutic effects, how long and frequent the sessions are, and directions for future research being making the TMS more personalized, faster, combining them with other treatments to hopefully make the effects more longer lasting. Thank you for listening. Here are my references here. Thank you.